During this lecture, we'll discuss eating disorders in addition to some childhood disorders related to feeding. Eating disorders are a relatively new field of study in psychology. They have only systematically been studied during the past few decades. Eating disorders, as the name implies, deal with disturbances in eating behavior. There are currently 6 eating and feeding disorders in the DSM. The first is anorexia nervosa, abbreviated as AN. The word anorexia nervosa literally means lack of appetite. Though individuals with AN are extremely good at restricting their food intake, and it may appear that they're able to do that because they're not hungry, that is not at all the case. People with AN are still hungry, and they do still have an appetite. Thus, this term is actually a misnomer. The same is true for bulimia nervosa, which literally means hunger of an ox. Although people with bulimia eat objectively large amount of food during a binge eating episode, they do not do it because they actually have a larger appetite than most people. It is because they experience a loss of control over their eating. Binge eating disorder is a newer eating disorder that was only officially included in the DSM in version 5, though it's been studied for a while prior to that. Pica and rumination disorder are 2 feeding disorders that are predominantly diagnosed in kids, and avoidant restrictive food intake disorder, or ARFID, is a brand new diagnosis that was added to the DSM-5. There are 3 criteria for the diagnosis of AN, all of which must be met. The first is that the individual restricts their energy intake relative to requirements, leading to a significantly low body weight for their age, sex, development, and physical health. So essentially what this criterion is saying is that the person is significantly underweight because they are restricting their food intake. People presenting for treatment for anorexia are typically about 25 to 30% below their expected body weight. To put this into context for you, if someone's body weight should be 100 pounds, they would weigh around 70 or 75 pounds. So they are quite substantially underweight. The next criterion is that the individual has an intense fear of gaining weight or becoming fat, or they engage in behavior that interferes with weight gain, such as significantly restricting their caloric food intake or engaging in compensatory behaviors to counteract caloric intake. I'll discuss more about that later. So the reason that these individuals are restricting their food intake is because the thought of gaining any weight at all is horrifying to them and significantly distresses them. Adults with anorexia will be able to verbalize that the reason for their low weight and associated behaviors is due to this fear of fatness, though children may not be able to articulate this. And so that's why this criterion can also be met by engaging in weight gain interfering behavior. The last criterion includes 3 possibilities. First, there may be a disturbance in the way in which one's body weight or shape is experienced. So even though the person is significantly underweight and objectively looks that way to others, they still perceive parts of their body as being fat or too big. It's kind of like BDD, where there is this misperception in the way that their body looks. The next possibility is that the person experiences undue influence of body weight or shape on self-evaluation. This isn't just that the person has a poor body image or low self-esteem. It's actually that the person judges how good or worthwhile or valuable of a person they are based primarily on their weight or body shape. So if we ask most people what makes them feel good about themselves as a person, most people will name a variety of factors, including things like their family, or their career, or their education. Some people may give appearance-related answers, but they're usually secondary to these other examples. For people with anorexia, their primary answer will be that they only feel good about themselves if they weigh or look a certain way. The final possibility for this third criterion is that the individual denies the seriousness of their low weight status. So for instance, a doctor may voice his concern to someone with anorexia that her low weight is very serious, and she could experience many medical complications and perhaps even die. And she will dismiss it and will do nothing to change her behavior. There are 2 subtypes of AN, and about 50% of people with AN fall into each of these subtypes. The first subtype is the restricting type, which is what is classically thought of as anorexia. In this subtype, people solely restrict their food intake. There are no episodes of binge eating or purging or compensatory behavior. I'll better define what's meant by this when we discuss bulimia, but basically it means that there's no evidence of eating a lot of food and then doing something to counteract the effects of eating that food, like vomiting. The second subtype is the binge eating purging type. Generally, I think people assume that binge eating and purging indicates that someone has bulimia, but that's not necessarily the case. People with anorexia may engage in that behavior as well, and in fact, approximately 50% of them do. There are some differences in this behavior, though, between individuals with AN and BN. In people with AN, their binges will not actually be excessively large. They will be nowhere near as large as in bulimia. Additionally, they are more likely to purge after almost every meal, while people with BN will only purge a few times per week on average. You might be wondering what exactly would determine which disorder someone who binges and purges has. The answer is weight. Low weight trumps everything because that is the most serious symptom. If someone is seriously underweight, they have anorexia, regardless of whether they are binging and purging. Finally, anorexia is diagnosed with a severity specifier, and this depends on their weight. Specifically, BMI or body mass index is used to determine severity. Typically, we consider a BMI between about 18 to 25 to be normal weight. So when a person is below a BMI of 18, they are considered underweight. You can see that mild anorexia would be diagnosed when BMI is about 17 and 18, while extreme anorexia is diagnosed when BMI is below 15. Here is a BMI chart so that you could get a sense of what this means. BMI is computed using a person's height and weight. One major criticism is that it does not consider muscle mass, so it can make people appear to be overweight when they're actually not. Thus, in determining healthy weight, BMI tends to be a better indicator at the low end rather than the high end. For someone to have a BMI of 14 and be in the severe range of AN, they might be 5'10 and weigh only 100 pounds. For mild anorexia, the individual might be 5'6 and weigh 105 pounds. Generally, individuals with anorexia are going to be given higher severity ratings than mild by the time they enter treatment, because they're at the point where they are very significantly underweight. Anorexia is the most serious psychological disorder in terms of risk of death. The risk of death for someone with AN is greater than for individuals with any other disorder, including depression, bipolar disorder, or substance use. This is largely because of the effects that severe food restriction has on the body, but it's also because suicide attempts and completion are extremely high in this population. One statistic is that rates of suicide completion are 50 times higher among people with anorexia than among the general population. Let's discuss some of the consequences that anorexia has on one's body. People with anorexia have a difficult time coping with the cold. Their hands and feet are usually cold to the touch and may appear sort of bluish or purplish. People with AN may develop lanugo on their face, neck, arms, back, and legs, which is soft, downy hair. This is clearly related to malnutrition and is thought that it may be the body's attempt to better regulate their body temperature by growing a fine hair on parts of the body. I'll show you a picture of this on the next slide. Additionally, the hair and nails of people with AN tend to be dry and brittle, and people may lose some of their hair. More serious side effects include the disruption in electrolytes, such as potassium, which can have really serious consequences for the person. They may develop heart arrhythmias or irregular heartbeat and can ultimately have a heart attack. They may also develop kidney damage or renal failure due to the imbalance in potassium. People with anorexia tend to feel tired, weak, and dizzy a lot because of their low weight. Adult women with anorexia will frequently experience a disruption in their menstrual cycle. This is because the menstrual cycle takes an awful lot of energy to maintain. If the person is no longer eating, there is no energy to maintain that cycle. So that's the first thing that the body shuts down. Next, the body consumes whatever fat is available and then starts eating at the muscle tissue, including the person's heart. This is another reason why so many people with AN tend to have heart problems. After that, the body will start eating away at the bone marrow and bone, which results in osteoporosis for many people with AN. Finally, the body will start eating away at the person's brain matter. Brain scans of people with anorexia have actually shown decreased brain density as a result of their disorder. Finally, the thoughts or cognitions of a person with anorexia are disrupted. They are no longer thinking clearly and tend to feel pretty depressed. What this means practically is that cognitive therapy ends up being very difficult for people with AN when they are underweight because they don't presently have the ability to effectively process and use information. The effects of medication also tend to be disrupted in people with AN because they're not able to metabolize them properly due to their low weight. In summary, AN is a really serious disorder and is something that can certainly lead to death if untreated. Here's a picture of Lanugo, but on a baby. When babies are developing in the womb, they are covered in Lanugo. They start to shed it shortly before they are born as they grow and put on some more weight. So these fine hairs can return in individuals when they're of low weight status, and they can commonly be observed in individuals with anorexia, particularly on their upper arms and their cheeks. People with AN often tend to try to conceal their low weight, not because they're embarrassed by it, but because they don't want to be hassled by other people. For instance, they may wear baggy clothes that don't show off their figure, or if they know they're going to get weighed at the doctor's office, they may place heavy objects in their pockets to make them appear to weigh more. Overwhelmingly, people with AN demonstrate perfectionistic traits in many areas of their life, but particularly when it comes to food and restriction. In part, it's thought that people with AN are successful in restricting their food intake because they are huge perfectionists and follow very rigid rules closely. People with AN tend to take pride in their ability to be very successful in restricting their food intake, and they may actually prepare food for others or watch others eat while not engaging in the food themselves because they like that they are able to have the restraint not to do so. When people with AN do eat, they tend to display ritualized eating habits, such as only eating alone or needing to cut up their food into very small bites or chew their food a certain number of times before they can swallow. The recommended number of calories that an adult should consume per day is around 2,000. A person with anorexia tends to consume fewer than 800 calories per day. Clearly, they are not eating much, which results in their low weight. They're not taking in enough caloric energy to sustain their body weight. AN is a rare disorder, though it's much more common among women than men. It tends to start fairly early in life, around mid-adolescence. However, people of all ages can have anorexia. It can be seen in children, and it's also definitely present in some older women. AN is unfortunately rather difficult to treat, and the symptoms tend to be chronic. One long-term research study that followed people with anorexia for 21 years found that only half of them had recovered from their symptoms over that time period, meaning that the other half had continued to have symptoms of anorexia for 21 years. More striking is that 16% of that sample had died during that time period, highlighting the risk of mortality related to this disorder. These are just some pictures of people with anorexia. You can see that they are clearly underweight, but remember that they don't view themselves that way. They still judge themselves to be fat or have an overwhelming fear of putting on any weight. The next disorder, bulimia, is one that probably many of you think you understand pretty well, as a disorder of binging and purging. However, there are some specific definitions that are important to know in understanding these behaviors. The first is with recurrent episodes of binge eating. Per the DSM, an episode of binge eating occurs when a person eats an objectively large amount of food in one sitting, typically within around a 2-hour period, but also when the person experiences a loss of control over eating. The second criterion, needing to experience this loss of control, is really necessary in differentiating large eating episodes that most people have from pathological binge eating. For instance, think back on your experiences of Thanksgiving. Do you think you ever ate an objectively large amount of food at one time on Thanksgiving? Probably most of us will say yes to that. However, during those times, did you experience a loss of control over your eating, such that you felt like you absolutely could not stop eating until all of the food was gone? Most of us will probably answer no to that. That's what differentiates a binge eating episode. People with bulimia will say that they are out of control while eating and cannot stop themselves. The next criterion that requires a bit of explaining is that the person engages in inappropriate compensatory efforts in response to their binge eating episode. This usually means that the person purges, which means that they vomit or use diuretics or laxatives or even enemas, and that's usually what we think of when we think of bulimia. However, The person with bulimia does not need to purge. They just need to do something to compensate for their binge, including purging, but also things like excessively exercising or fasting. The purpose of the inappropriate compensatory behaviors is twofold. First, to try to rid of the calories that they just ingested from binge eating, but also, and probably most importantly, to alleviate the person's negative affect or mood following the binge. After people binge, they feel pretty bad about themselves. Purging or other compensatory behaviors remove those bad feelings. Thus, the compensatory behaviors are maintained through negative reinforcement, since they're more likely to keep occurring following a binge because they take away the person's bad feelings. These episodes of binge eating with inappropriate compensatory behaviors must occur at least once a week for 3 months. Additionally, similar to an anorexia, the person's self-evaluation or self-worth is unduly and largely influenced by their body weight and shape. Said another way, their judgment of their worth as a person is largely and primarily determined by how much they weigh. For bulimia, severity is determined by the frequency of inappropriate compensatory behaviors. Someone would have mild bulimia if they are purging or engaging in some other compensatory behavior, like fasting or excessively exercising, between 1 and 3 times per week. And they would be considered severe if they were doing it at least 14 times per week. Remember, in most cases, people with bulimia are not binge eating and purging at every meal. It only happens intermittently throughout the week, though the more often the inappropriate compensatory behaviors occur, the more severe the disorder. Bulimia also has many negative effects on the person's body. Similar to anorexia, there's certainly a high risk of suicide. However, the disorder is not as fatal as anorexia because the person is not starving themselves. Many of the negative effects result from the purging behavior, so you see a lot of problems with the person's mouth and throat. The person may have tooth erosion or gum disease from vomiting frequently, and they may have irritated throats or tears in their throats. Tears may come from the throat being scratched if a person needs to use a foreign object to induce vomiting, if their gag reflex is no longer sensitive. Many people with bulimia can actually vomit on cue without needing to stick anything in their throat, due to conditioned behavior, but some people still need that trigger. Eventually, they habituate to using their finger and their gag reflex is no longer triggered, so they may need to use a longer object, such as a toothbrush, to induce vomiting. This object could tear the back of their throat. There are some very rare instances where people have gotten foreign objects like toothbrushes lodged in their throat as a consequence of using them to make themselves vomit, and they have to go to the ER. Some people with bulimia will also appear to have chubby cheeks or chipmunk cheeks. This is because their salivary glands become irritated and swollen from frequent vomiting. People may also have calluses on their fingers or hands from using their fingers to make themselves vomit, and these parts of their hands repeatedly are rubbing against their teeth, causing calluses. Similar to anorexia, people with bulimia also experience disruptions in their electrolytes, which can lead to heart problems. They may also experience a disruption in their menstrual cycle, though it's not as common as in anorexia. If people are using laxatives as their compensatory behavior, they may experience GI issues as a result, like chronic constipation. On this slide, you can see an example of what a person's binge eating episode might look like. Whereas a person with anorexia may only consume around 700 calories in an entire day, a person with bulimia may consume as many as 4,800 calories in a single binge eating episode. Food that people typically binge on is food that the person finds good. It tends to be high in calories. No one really binges on broccoli. So instead, within a 2-hour period, the individual may eat all of a half gallon of ice cream, an entire bag of chips, a whole package of cookies, and a whole loaf of bread with peanut butter smeared on the top of each piece. The binge will often last until there's no food left, and the person may even purge during the binge, but then go right back to eating. People with bulimia tend to be around normal weight. They're usually within 10% of their expected body weight. The main reason they're not underweight, even though they're compensating for their binges, is that the compensatory methods are not actually very effective. When someone vomits, they only get rid of about 50% of the ingested calories. The other methods of compensating barely rid of many of the calories. Thus, they're really inappropriately compensating for the caloric effects of their binge because the compensatory behaviors don't actually rid them of the calories they just took in. However, they're not substantially overweight either because they're not binging every time they eat. At minimum, it's only happening around one time per week. They're not necessarily consuming more than their recommended calories on a daily basis. Bulimia is more common of a disorder than anorexia. Similar to anorexia, though, bulimia is more common in women. The age of onset is slightly later in life than for anorexia. This is largely thought to be because people will start out restricting their food intake, as in AN, but many of them just aren't able to continue to restrict because it's really hard to do so. So they have a binge eating episode because they're hungry and the temptation is great. But then they feel bad about it and about themselves, and they're worried about gaining weight, so they purge. Now the cycle of bulimia has begun. Luckily, the overall prognosis of bulimia is much better than for anorexia. It's easier to treat, and many people do get better over time. One study found that after following people with bulimia for 12 years, 70% of them had gotten better. That is a much better statistic than for anorexia. The last eating disorder, binge eating disorder, or BED, is new to the DSM, but it's been studied since the 1990s. In this disorder, the person engages in binge eating episodes at least once a week for 3 months. The definition of binge eating is the same as for bulimia: eating an objectively large amount of food in a discrete period of time and experiencing a lack of control. The person must also experience at least 3 of the following symptoms: eating extremely quickly, more so than usual, eating until they feel uncomfortably full, which is likely the case for most binge eating episodes, eating a ton of food even when the person is not at all hungry, wanting to only eat because the person is embarrassed about the amount of food they are eating and feeling disgusted, guilty, or depressed following a binge episode. People with bulimia are likely to experience many of these symptoms as well, but remember that they also engage in inappropriate compensatory behaviors. People with BED will not engage in any compensatory behaviors, so their binge eating episodes must be associated with these other behaviors for the diagnosis. Finally, the person must experience distress about their binge eating. The time duration is the same for bulimia. These episodes must occur at least once a week for 3 months. For BED, severity is determined by the frequency of binge eating episodes. The disorder is mild when the person is binging 1 to 3 times per week, and it's severe when the person is binging 14 or more times per week. Binge eating disorder is associated with being overweight. About 65% of people with BED are actually obese. It is again more common among women, and it is the most common of the 3 eating disorders. However, it usually tends to begin a little later in life than the other 2 eating disorders, and is the most likely to have its onset in later adulthood. The eating disorders are not largely stable over time, meaning that many people switch from one disorder to another and possibly back again. This figure uses arrows to depict which disorders people are likely to switch between. The thickness of the arrow denotes how likely it is to occur. Thus, you can see that many people switch back and forth between the different subtypes of anorexia. People are also relatively likely to go from anorexia binge purge subtype to bulimia, depending on their low weight status. It's rare that people will switch between BED and bulimia, but it does happen. No one will ever go from AN to BED though, at least not without passing through bulimia first, but that is still very unlikely to occur. There are a few biological factors relevant to the development of eating disorders. First, eating disorders run in families, especially anorexia. It's thought that certain personality traits associated with the disorders are what is specifically inherited. For anorexia, that personality trait is perfectionism. For bulimia and binge eating disorders, the personality traits inherited are likely impulsivity and/or negative affect. There are neurotransmitter abnormalities as well. One of the many roles of serotonin is to regulate eating behavior, specifically to regulate when a person feels full from eating. Serotonin is thought to be too low in bulimia and BED, and dysregulated in anorexia. At times too low, but at times too high. Dopamine plays a role in reward seeking. It's thought that to be too high in bulimia and BED and too low in AN, making it less likely for them to be motivated by food. Finally, it's thought that the hypothalamus may play a role in eating disorders. The hypothalamus is involved in motivated behaviors, which are behaviors that we are motivated to do to stay alive, such as eating. There may be some disruptions in its functioning, contributing to eating disorders. A major psychological factor related to eating disorder is family dysfunction. It's thought that parents of people with anorexia tend to be rigid and overprotective, and tend to exhibit the trait of perfectionism. Many people with anorexia will say that their parents, especially their mother, are super controlling, and the only thing that they feel like they can control in their life is what they eat. Therefore, they're going to hold on to that and to control the one thing in their life that they can, resulting in very restricted eating and low weight. The parents or family members of people with bulimia tend to hold high expectations for their children, are likely to be dieting themselves, and make a lot of negative and critical comments about the weight or body shape of others. They may be inadvertently communicating to their children the perceived importance of weight and shape, and in order to achieve these standards, the individual begins engaging in eating disordered behaviors. Many people with eating disorders report a history of sexual abuse as a child. It's unlikely that experiencing sexual abuse actually causes eating disorders. It's likely that this is a correlational finding. It could be that experiencing childhood sexual abuse makes a person more likely to either want to control things around them, leading to anorexia, or that it induces chronic negative affect, leading to bulimia. The exact pathway is unknown, but a history of sexual abuse is somewhat common among individuals with eating disorders. People from higher socioeconomic status are more likely to have an eating disorder, as are Caucasians. African Americans are least likely to have eating disorders. It's likely that societal pressures to be thin may be more directed toward or salient to white individuals from higher economic backgrounds. As I mentioned during the first lecture, bulimia is thought to be a culture-bound syndrome, meaning that it's only found in certain cultures, and not everywhere in the world. Anorexia is found in all cultures, but bulimia is not. Specifically, bulimia is only found in cultures that have exposure to Western media and ideals, and that also have access to plentiful food and private places to purge. A really interesting study demonstrating that bulimia is culture-bound was conducted by some researchers who are looking at symptoms of bulimia among adolescent girls on the island of Fiji. At the beginning of this study, Fiji did not have access to Western media, but the researchers knew that they were going to gain access in the upcoming years. So they first assessed the girls there before they had access to American TV or magazines. There were no instances of binge eating or purging or other inappropriate compensatory behaviors. And for the large part, girls were pretty accepting of their body and had a healthy body image. After Fiji got access to American TV shows and magazines, the researchers again assessed adolescent girls about their eating behaviors and body image. Although they did not find that girls were yet binging and purging, they found a significant difference in their body image and their perception of their self-worth being based on their body shape and weight, which the researchers concluded was a precursor to bulimic behaviors. Thus, the media and the society we live in greatly influence our perception of our body weight and shape and the importance that we give to it. In our society, being thin is the ideal. The models we see in magazines and most people on TV and in movies are thin, especially women. However, it is becoming increasingly difficult to obtain this thin ideal. As a society, we are increasingly getting larger instead of smaller. Some of this is due to the lifestyle that certain people have, but also this is due to continuously improved nutrition and our genetics. Thus, for many people, being super thin is not easily possible, making losing weight and trying to obtain this thin ideal very difficult, which may make people resort to engaging in eating disordered behaviors. Finally, one study on Barbie dolls shows the influence that even dolls may have on girls' body image. Researchers studied little girls who had never played with Barbies before. Half of the little girls were given a Barbie to play with for a while the other girls were given a doll that didn't convey any information on body shape or attractiveness. Afterwards, the researchers asked the little girls questions about how much they liked themselves and the way they looked in their bodies. The girls who had played with Barbies reported liking themselves and their bodies less than the girls who didn't play with Barbies. Thus, there's likely many things in life and in our society that may ultimately contribute to the development of eating disorders because we compare ourselves to them, many of which are just not even attainable. To demonstrate just how unobtainable Barbie's image is, a life-size Barbie was created. As it turns out, her proportions would not even be possible in a real person. She would be 5'9", have a 39-inch bust and an 18-inch waist, and weigh only 110 pounds. Therefore, she'd have a BMI of 16. She would likely not be able to walk upright because her proportions would make her too top-heavy and she wouldn't be able to support herself. I've largely been talking about eating disorders in women, but they do occur, albeit much more rarely, in men. Men with eating disorders are more likely to be homosexual or to engage in hobbies or occupations that require low weight, such as wrestling or being a horse jockey. In men with these sorts of jobs or hobbies, they may engage in eating disordered behavior such as fasting or binging and purging during the time of the year that their sport is active, but resume relatively normal eating behavior in the off-season, indicating that the disorder is functioning differently in these guys and is likely not as pathological. On the other hand, men may be driven to be larger rather than thinner, at least larger with regard to muscles. This drive for muscularity is called muscle dysmorphia. This is a term to describe abnormal eating and behavior related to men's desire to gain muscle mass. If a person experiences intense preoccupation with the idea that their body build is too small or insufficiently muscular, despite that not being accurate, the person could be diagnosed with BDD with a muscle dysmorphia specifier. Similar to how Barbies influence girls, toys may also influence boys, but to be larger. This picture shows G.I. Joe. The two on the left are from 1982. The one on the right is from 1998. You can see how the shape of G.I. Joe has changed over time, looking like a relatively normal guy at first, and now looking huge and muscular. And with that, it has likely influenced little boys' drive to be muscular in the same way that Barbie has influenced little girls to want to be thin. Moving into talking about treatment for anorexia is very difficult. The first priority is that the person's weight needs to be restored. Not only is very low weight extremely dangerous, as we discussed, but also no other treatment is going to be effective until the person has gained some weight. When people are at super low weights, their thought processes and ability to think logically and rationally is seriously impaired. So psychotherapy is not going to be effective until weight can be restored, which restores their cognitive abilities. Additionally, at a super low weight, medications are not effective because the person does not metabolize them in the same way that they would be metabolized if they were at a normal weight. Thus, for many reasons, restoring weight is the immediate concern. However, most people with anorexia do not want treatment, and gaining weight is the last thing they want. Remember, they're scared of gaining weight and becoming fat. Some people with anorexia will need to be committed against their will, which is a possibility if they are refusing treatment but are a danger to themselves or can no longer care for themselves. Starving themselves can be considered being a danger to themselves. Even if they are hospitalized, still many will refuse to eat, and some patients may require internal feeding or a feeding tube to be surgically implanted in their stomach, or they may have a tube placed down their throat to feed them that way. So in people for whom eating is already really scary, being force-fed like this makes eating all the more unpleasant, but keep in mind that it's medically necessary. The most effective psychotherapy that we have for AN works for adolescents. Family therapy can be effective for adolescents who have families who are willing to get involved and who enter treatment relatively early in their eating disorder. The earlier someone receives treatment, the better their prognosis. Family therapy tries to change family patterns of eating and negative and dysfunctional attitudes and communication among family members regarding food and eating. Meals are structured so that the family eats together, and they learn how to make meal times more enjoyable. First, there is a refeeding phase where the therapist works with the parents and supports their efforts to help their child eat healthily. During this time, meals are observed by the therapist who can help provide tips to the parents. After the adolescent has begun eating again and starting to gain weight, therapy enters a new phase of negotiations for new patterns of relationships where family issues and problems are addressed, such as family members being overly controlling, Family therapy lasts anywhere between 6 months and 3 years. So clearly, it takes a while to effectively treat this disorder. Unfortunately, there is not a comparable treatment in adults, since it would be extremely difficult to get an adult's family involved in structuring mealtimes, and even if they did, or engage their spouse or partner, it is difficult to achieve the family dynamics that are necessary here if the client is already an adult. CBT, then, is the psychological treatment typically used for adults with AN. It focuses on modifying distorted beliefs about weight and food, such as the belief that if they eat a little bit, that they will lose control, and that they are only a valuable person if they weigh or look a certain way, and attempting to diminish anxiety over gaining weight. CBT is only mildly effective. This may in large be part due to the pervasiveness of the rigid thoughts and perfectionism that go along with this disorder. It's very difficult to change. To date, there are no studies indicating that medication is very effective for anorexia. SSRIs and atypical antipsychotics have been used for AN largely to try to make the person gain weight, since these medications tend to make most people gain weight. However, because they are not metabolized in the same way when people are significantly underweight, and because food intake is still necessary to make them gain weight, they're not that effective. As I mentioned before, the prognosis for bulimia is better and treatment is more effective. CBT is again used, but it is more effective than for people with AN. CBT for BN involves educating them on the fact that their compensatory behaviors are not actually ridding them of calories they just ingested. It also involves having the person structure several small meals throughout the day. This will decrease the chances that they get really hungry and potentially lead to a binge, which decreases the chances that they will purge. Additionally, they learn coping strategies and learn other more adaptive behaviors that they can engage in when they are feeling the urge to binge or purge. Similar to in anorexia, they will also work to challenge the person's perceptions and beliefs regarding physical attractiveness and being thin. IPT, or interpersonal therapy, is also effective for bulimia by focusing on improved interpersonal functioning, including improving interactions and dynamics with family members who may be overly critical regarding weight. We discussed IPT when we talked about mood disorders because it is equally as effective as CBT for depression. The same is true for bulimia, though it takes longer initially to work, so CBT is ultimately preferred for the treatment of BN. Finally, medications such as SSRIs are effective for BN because they can alleviate comorbid depressive symptoms, as well as decrease episodes of binge eating. People with bulimia are normal weight, so medication can be metabolized in the appropriate manner. Psychotherapy, including CBT and IPT, are both also effective for BED. SSRIs and appetite suppressants also work well. Additionally, a specific stimulant medication, Vyvanse, was recently approved for the treatment of binge eating disorder. This medication is typically prescribed for ADHD, but it's been found to work well in helping to reduce episodes of binge eating as well. Importantly, self-help approaches have been found to be effective for BED. What this means is that a person can obtain a guided treatment manual that they will work through themselves. This can easily be done with the assistance of the person's primary care doctor, and it has been shown to be very effective. And it decreases the amount of time the person would spend in therapy or the costs associated with treatment. However, the person needs to be motivated to change in order to have the initiative and follow through to complete this treatment and see changes. All of these treatments are also more effective compared to typical weight loss programs, because those programs will not address the binge eating. The next disorder is a feeding disorder, and it's typically seen among children. However, it is also sometimes seen among pregnant women. PICA involves the persistent eating of non-food substances. This can include anything that's not meant for eating and doesn't carry nutritional value, like eating dirt, paper, chalk, or string. This behavior must occur for at least 1 month and must also be inappropriate to the developmental level of the person. Specifically, it's recommended that the child be over the age of 2 to exclude babies and toddlers who are prone to putting all sorts of things in their mouth. Causes of PICA are unknown. There's no standard treatment, though it's based on behavior modification with a focus on reinforcing the eating of appropriate food substances. The next feeding disorder is rumination disorder, which is also most likely to occur in children. For this disorder, the person chews and swallows their food, but then regurgitates it or throws it back up into their mouth. At that point, they may spit it out or they may rechew and reswallow it. This behavior must last at least 1 month, and it typically occurs on a daily basis. This behavior must not be due to any gastrointestinal or medical problems, so there's no clear reason for why the kid is not keeping his food down. This disorder may occur in very young kids and is typically diagnosed in kids between the ages of 3 months and 1 year. Similar to pica, causes are unknown. Treatment tends to involve mild aversion training, where rumination behavior is associated with negative consequences, and keeping food down is associated with positive consequences. Finally, the last disorder in this section is ARFID. Not a lot is known about this disorder yet, since it is brand new. People with ARFID may initially look like they have anorexia, because they're likely to be underweight. However, this disorder does not involve any fear of fatness or gaining weight. So that would be the particular criterion to pay attention to in order to differentiate these two disorders. So for ARFID, the person has an eating or feeding disturbance, which means that the person is not eating much. This is typically due to an apparent lack of interest in eating or in food, and may be based on certain sensory characteristics of food. This eating disturbance results in failure to meet appropriate nutritional and/or energy needs, typically meaning that the person is underweight or malnourished. Specifically, they must meet one of the following 4 criteria. They need to experience significant weight loss or must fail to gain weight. They must be determined to have a significant nutritional deficiency resulting from this disturbance. They must depend on internal feeding, meaning that they are receiving the delivery of nutrition directly into the stomach and bypassing the normal oral route of eating, or that they are dependent on oral nutritional supplements to keep them from malnourishment. Or finally, there is marked interference with psychosocial functioning. This last criterion may seem a lot different and less severe than the prior 3. This possibility is included in order to not miss individuals who have an abnormal eating or feeding disturbance that may not result in them becoming significantly underweight or malnourished, but it's still significantly impairing their life. One of my friends who is an eating disorder researcher jokes that her husband should be diagnosed with ARFID because he refuses to eat most foods, predominantly due to a lack of interest in trying them. While he's not significantly underweight or malnourished, his eating repertoire is extremely limited, and this has periodically caused some psychosocial problems for him related to going out to eat with friends or being able to find something to eat at social gatherings, which might prevent him from going altogether. To highlight the restricted repertoire that he has, one of the last times I spoke with my friend, she told me that her husband, for the first time ever, recently tried a smoothie. Let me convey that this is an adult man. My friend had been telling him that smoothies were good and that he should try one, but he always refused. She finally got him to try one recently, and it turns out he likes it. But prior to that, he had no interest. Finally, for this diagnosis, the eating or feeding disturbance cannot be due to a lack of available food or associated with culturally sanctioned practices. Specifically, this means that the person's food repertoire cannot be limited solely because the person does not have available options of food to eat. And it's also not due to accepted eating practices in our society, such as being gluten-free or vegan. The remaining slides all include the What's the Disorder exercise. As usual, please go through them yourself to try to identify the correct disorder and contact me with any questions or to review your answers. So here's the first one. Trevor is 5 years old. For the past 6 months, he has been frequently trying to eat objects such as pencils and chapstick. Trevor's mother has to constantly watch him to ensure that he is not eating items other than food. Pam spends a lot of time weighing herself to see if she has lost weight. She's extremely anxious about gaining weight and sees herself as fat and ugly, even though she is significantly underweight for her age and height. Because of this, she regularly makes herself vomit after eating meals. She has felt this way and engaged in this behavior for the past 6 months. Stephanie believes that she needs to lose weight. She thinks of herself as a loser because she is not as thin as most of the women on TV. She frequently attempts to diet, but finds that she will end up eating a substantial amount of junk food a few times per week. During these times, Stephanie feels as though she cannot stop herself and will continue eating until there is no more food left. Stephanie usually feels anxious about gaining weight afterwards, so she will make herself vomit. This has been occurring approximately 2 times per week for the last several months. Marilyn regularly eats when she feels upset. She will usually eat a bag of potato chips, several celery stalks with peanut butter, a package of cookies, and 10 candy bars. During these instances, Marilyn feels that she cannot stop herself from eating and will eat until she is uncomfortably full. She eats alone because she is embarrassed about the amount she is eating, and she feels very depressed and guilty after these episodes, which have been occurring approximately 3 times a week for the past year. Amanda frequently vomits up her food back into her mouth shortly after swallowing it. After doing this, she will chew her food again before re-swallowing it. This has concerned Amanda's parents because she never used to do this prior to the past 2 months. Zoe regularly exercises with the sole purpose of losing weight. She will exercise for up to 6 hours per day. She also makes sure to only eat healthy foods, though she tends to eat very little and will often only eat once a day. She's very afraid of gaining weight, though she is now severely underweight. She continues to engage in this behavior because she believes that her thighs and butt are too fat. Lori believes that she is overweight, even though she is not. She believes that she is not a good person unless she is thin and beautiful. Lori attempts to restrict her food intake, though she will often engage in binge eating. To make up for the calories that she just ate, Lori will often fast, sometimes for more than a day. She has never vomited after eating. This occurs approximately twice a week. Katie is a 14-year-old girl. She is not afraid of gaining weight or getting fat, though she is underweight for her age and eats very little. In fact, she has lost 20 pounds over the last year instead of gaining weight in accordance with her growth and height. Katie says that she just doesn't like to eat and doesn't like the taste and texture of most foods. When pressed to try a new food, Katie will refuse. She has largely stopped eating dinner with her family and will not go out to eat with her friends because of this.